out loud and clear, and that is, as we design this, and as we just heard in our last session, it's all about sustainability. When we start to do this, not how do we do something good in just the short run, but how do we do something good at the long run? And when we talked about that, we realized we were talking about sustainability in two different dimensions. One is sustainability in terms of an area of quality improvement that we've done, such as reducing elective deliveries or reducing line infections. The other was sustainability of quality improvement overall at a provider level, but also at a collaborative level. And when we started to talk about this, there was no one else who came to mind but Jeff. Jeff was here with us a little over 2 years ago in Gainesville to help us figure out if we wanted to get started, and the answer was yes, loud and clear. No one has been doing it as long and knows as much about the issues of sustainability at all those levels as Jeff, and we welcome him back to share his next round of wisdom for us to learn.
I love these intros. They're just so great. I'll start off with two little stories and then go into this. In the first story is that a while back, gosh, it was a long while back, we were thinking of doing something like this, and we were told about this model called Storks. And Storks was a really big model in either Oregon or Washington. Everybody talked about Storks, you know, and then when we went to try to find out about it, almost no one knew anything about it, and it had closed down for only like 3 or 4 years, and no one knew anything about Storks. And Storks was a perinatal quality improvement project, and it was a huge top-down project that when the money stopped, it just disappeared. And that was a terrible lesson for us, and we decided that was not going to happen in California, that whatever happened to Storks, that we had to be a grassroots organization, and that's what we were going to do. So that was kind of like one of the things as we woke up one day and started doing this that was ingrained in our head. We're not going to go the route of Storks. The second thing is that for about 1.5 years prior to getting started, David Stevenson and I had worked as consultants for a company that was developing a product. And we would come in with these great ideas, you know, like you should have a laminated thing on the delivery room wall that says the risk things, and then they'll know. And we would present this great idea, you know, which we had presented to our, you know, to our neonatal colleagues who would, oh yeah, great idea. And these guys would look at us and they'd say, what value is that? And we had never been asked that question. And we said, well, gee, you know, it's laminated, it's on the wall. They can say, but what's the value of that? I mean, you know, can you define it? Can you put it into some context? And for like 1.5 years, we worked with them, and every time we had an idea for a form, for a collection of data, they'd look at us and they'd say, what value is that? So we were kind of got value brainwashed. And so when we started this CPQCC, the whole thing was, well, we got to build value in it because that's what these successful business people do. And so those are two things I wanted to kind of start off with, is this notion of sustainability and value, and they're really quite intermixed. So we're going to talk about two kinds of sustainability. One is a collaborative, and I think that the key here is to provide high value to those whose support is essential. And I guess we could all leave now. I mean, that's really it. That if you want to have a collaborative that's that's sustained, you have to provide value to those whose support is essential. I mean, that's rock bottom. So and we'll talk about some of how that works, or how it could work. And then in terms of a project, we have to integrate new processes and assessments into the hospital's culture. Now, culture is a kind of a fancy word. You know, you read about these culture, you wonder, what's that really mean? Well, culture, simply stated, is the way we do things around here. That's what culture is. You know, that it's just the way you do things. So how do you integrate new processes and assessments into a hospital's culture. I mean, you know, why do anything different? I mean, we've been doing it some other way for a long time, and it's comfortable, and why should we change? And when we change, why should we keep doing it? So those are kind of the foundations of sustainability that are worth thinking about. So the goal is to build value. And when you're thinking about building value, it's probably worthwhile to think about the why, the how, and the impact. So a mission statement becomes really important. And the reason it becomes important is it gives clarity of direction, and it helps you recruit stakeholders. And the stakeholders may have very different reasons for what they want to do. They may have very different reasons. So, like, one of our initial stakeholders was Pacific Business Group for Health, that were seen as the enemy. I mean, all they wanted to do is have us post our results on websites, and they had the philosophy that if a place wasn't performing, they should go out of business. We had the philosophy if a place was challenged, we should help them, bring them along. So here we've got these two key components to building this organization, completely at odds in terms of some very fundamental features. But, you know, the mission statement was to improve the health of all pregnant mothers and their infants, and both organizations profoundly believed in that. So although we had differences, really big differences, when we got into a fight, which was not that infrequent, we could always pull back to the mission statement. We could always say, well, you know, our mission is to provide the best health for moms and infants, and that could stop the fight, and then we could start the negotiation. You know, so how can we do this? You know, how can we reach some kind of negotiation, because we both want the same thing? So very, very important to have a mission statement that is clear, and as you go into this, there's a specific way to put together a mission statement. Oftentimes, I remember, I think when I came here the first time, but oftentimes people will come and say, we want to build a collaborative. This is before Vaughn was providing a lot of regional data. And how much should we put aside for building our database and our IT team? And I would say, don't do any money on that. What you're trying to do is to put together a complex organization. What do you know? In medical school, did you learn about how to put together a complex organization, or in nursing school, or in public health school? Well, a little bit in public health school, but even there, not very much. So if you have any money, get yourself someone in organizational development who will be able to come in and help you get these very different stakeholders to come together, to commit, to build your mission statement, to get aligned. And I think it's really important. When we started the maternal CPQCC, I had said this, and so we found some really good. And when he sent in the bill, I almost died, because these people are fairly expensive unless you can work through a university and get a graduate student to write their thesis on it or something. But it turned out that we had very contentious folks, and within 3 executive committee meetings, everybody agreed on the mission statement and the approach and the stuff, and it was amazing. I sat there dumbfounded from where we started off in the first meeting. But again, this is because we had a professional whose life and career and experience was how to put together a very complex organization. So that's the kind of the why of it, I guess. So the how is putting together tools and facilitating execution. And one of the things that I think all of our collaborators have going for us now is that there are tremendous demands for quality. It's from CMS, it's from JCO, it's from your local Blue Cross, it's from anywhere you can think. And more it's from the consumers, as March of Dimes starts to reach out to consumers about the importance of various appropriate ways of doing things, better ways of doing things. There's going to be tremendous demand. And so the collaborative has the possibility of putting together the tools, the toolkits, And toolkits, you know, we have a wonderful toolkit, and maybe about 50% or 70% will actually work in Florida. So you start with something really good, but then you have to refine it so it meets your own needs. And then once you have the toolkit, well, that's great, but you just heard that it's really important to have a collaborative. We're doing a study where we had about 30 NICUs on a IHI, very intensive face-to-face delivery room management. And then we have 30 that we gave the toolkits in the one WebEx that were doing it on their own. And what we found out, we're still analyzing the data, but it's really clear if you do it on your own, it's almost like AA, you know, like when you're doing very difficult things like alcohol, like trying to give up drinking if you're, you know, an alcoholic, it's hard to do it on your own. You really need mentorship. You really need people that, you know, when you're, oh, it's too busy for us to, we're going to just stop this class. I mean, it's just too busy to really say, wait a minute, you got to really keep going. So the team, you know, the collaborative helps your motivation, helps you do these difficult things, especially when you're over-censused and when there's a lot of stuff going on. Very important. Collaborative is very important. One of the things that we found is that they've said, can we have a listserv the next time? It's great to do it on our own, but boy, we wish we could know who else is doing it so we could see if they've solved this problem. And this is one of the things we heard is that when you have a collaborative, one team may solve one problem and another team solves another problem. They get together and there's a lot of sharing and not reinventing of the wheel. So facilitating execution is really important. The idea that you're not only doing tools, but you're putting together structured collaboratives that will help folks do the job. And then impact is important, and it's really important to realize that the outcome is not the impact. The impact is the value that's seen. So there's institutional impact, stakeholder impact, family impact, and I've been writing down things, but the really profound thing that was said in the last talk was that they did presentation dependent upon the audience you're speaking to. Remember, that you speak to nurses, you show the Gabby. You speak to administrators, you show the money. If you're speaking to physicians, it's really, really important. The outcome is just an outcome. I was so disappointed. We had a collaborative on our antenatal steroid collaborative, and we went in the newspapers called, and actually the first I went to a hospital administrator because we're so proud about this because they had helped us with it. And I said, we had done such and such improvement, and he looked at me and said, oh, that's great. And I was I was broken. I mean, like we were so excited about this as physicians. We had increased antenatal steroids and all this stuff was going to happen. And then he said, like, wow, it's like I'll have a chicken sandwich, please. It was just terrible. And then the press called, so we were, press release, and we told them. And so they said, oh, well, how many lives did that save? And were the parents happy about that? And on and on and on. And we were so hung up on the outcome of increasing antenatal steroid that we never realized that presentation is dependent upon the audience you're speaking to. So the outcome is not the impact. It's really important to sort out what is the impact. So one of the things that is very important is building stakeholder value. And you have to really, when you have your stakeholders, but your stakeholders are not, I don't know, like I grew up in a situation where the stakeholders were almost like rubber stampers. Oh, we're going to have this, we're going to do something. Oh, we got to have this group, we got to have that group. And it was almost like in public health school, you needed the stakeholders, but they never taught us why it was important. It was almost like, well, they're in the field, so somehow you got to bring them into the tent. But it was never really said, you have to bring these stakeholders, and somehow you have to build a collaborative where you meet your stakeholders' strategic goals. So one of the things is you have to ask yourself, how can your activities become essential to actualizing their mission? Really very, very important. And the missions are quite different. You know, hospital administrators want to save money, or maybe they've been dinged on their patient satisfaction. So what they really want to do is generate patient satisfaction. So it's really, really important to understand what it is that is actually the mission of your stakeholders and how you can contribute it to that. We had, when we started off, some of our money was from Title V, and I happened to look at the state of California's Title V report, you know, that they submit to the feds, and none of the stuff that we were doing was on it. And I thought, wow, this is crazy, you know, like the stuff we're doing really fits right in with what the state's supposed to be doing. So we try to do that. So what it meant is that when you have a stakeholder, you really have to sit down with the stakeholder, find out what their mission is, and really discuss how it is that what you're doing can address their mission. And in some cases, it means you have to change what you're doing a little bit so that it'll actually work. But very, very important. And then it's also important, I don't know if anybody remembers the women's rhetoric. That was a really important movement when I was younger. The women's rhetoric movement was all about recognizing advancement. And one of the things that they felt was very important is that you could never get true advancement unless you looked at all the negativities. So a lot of times, you know, you bring in a group, but it's not politically correct to discuss all the stuff about this. So you might have teenage mom prevention, and you bring in the teenage moms, but you don't really start to talk about all the negativity that's around that surrounds this. And what happens is that it creates kind of this false, it blocks intimacy. So you can ask Vital Statistics to be part of this. And you could say, well, it's great, blah, blah, blah. But the negative impact is that if you're producing those reports and your State Office of Health Planning Development is producing those reports, then one of these days the governor may say, why am I paying you in this fiscally hard time to do these reports when your Florida Collaborative is doing those reports? So very, very important to start to think about when a stakeholder joins your organization or supports, not only how can you meet their strategic goals, but what negative possibilities does that bring up for that stakeholder, and how can you get over that? And you know, we had a little, sometimes March of Dimes, it wasn't a big deal, but there was a question of what was March of Dimes' role in the toolkit and what was our role. And there was a really, you know, it took a while to figure it out, but one of the things that March of Dimes prides itself in is reaching out to people. And so there was concern that if the docs who put this together got incredible credit, that could decrease the visibility of March of Dimes reaching out to people. I know this, to some people it may sound petty, but it's a really real thing that you have to think about. So we spent a lot of time on that cover. It just probably flashed by you. But the cover, we spent a lot of time on the cover so that there would be, people would be comfortable with the role, with the presentation of their role in a way that met their strategic goal and didn't disempower them. And I know that this sounds, off the wall, but it's very, very important. And some groups could have done this and not even thought about that, and maybe the thing would have been published, but there would have been underlying animosity. There would have been, it wouldn't have worked quite the same way. So what I'm saying is that as you build stakeholder value, not only look at the positive things, but really try to anticipate what some of the negative impacts of a stakeholder joining. For example, when Pacific Business Group on Health joined with us, that all of a sudden let's get this stuff out, just didn't happen. And so when they went to their executive board and said, well, we're funding this thing, and the executive board said, oh, it's going to be in neon signs what everybody's doing. They say, well, no, it's not going to work that way. There's going to be a group description of the group was here and then the group was there. They took a lot of heat for that, that they were supposed to be individual level things coming out. So again, by starting to discuss this stuff, first anticipating it and bringing it up with them, what are some negative impacts, and then they'll start to tell you some of their negative impacts. And the whole trick is to, like with risk benefit, is to decrease the risk and increase the benefit. So I spent a lot of time on that because you can't see it in books. It's really not in books, but it was something that was very important to us. So we try to look at what are what are the values? Well, we provide, what are we doing and what's the value? Well, we provide volume and demographic data, so we could give that to administrators for planning and strategic development. Here's what a real intensive profile of what's going on in the NICU. We provide process and risk-adjusted outcome data, so that guides QI activities. It meets payers' requirements on contracting. Oftentimes in California, although all this stuff is confidential, we've heard that certain payers will say, well, down the street they're offering us a much lower rate. Why should we give you this rate that you're asking? And then show us your Vaughan data. And so there's that, although people don't talk about this, that at least in California, we know that part of negotiating is based on the quality of the output. We also prepare mandated California Children's Service reports. These reports really deal with, does capacity match need? Do the QI activities match the outcome? So this is a report that was very onerous in the past, and now we just take most of it right off the database and prepare that for our members. We facilitate the California Hospital Assessment and Reporting Mandate, and one of the things that we've been trying to fight for is quality indicators that are malleable, that in other words, if someone is promoting a quality indicator, we try to make sure that there's proof that you can actually change that outcome. So again, there's just a whole bunch of things. Not important to go through each one. You can kind of read them, but it's important to sit down and think of all the ways in which you might be able to, your collaborative can really bring value to both the members and the stakeholders, as well as the way that you might have risks. Now, one of the risks that people saw in California was both good and bad. Initially, it was thought that the reason that we were doing this, especially out of Stanford, was to put small places out of business. And it was really, when we first proposed this, it was seen as a ploy for some of the big academic centers and the big private centers to really create a situation to put the small centers out of business. And so because of this, we had to, all the data centers went into state office buildings, and we really relied upon the state for a lot of things. As we got more and more credibility, we were then, and people realized that that wasn't the goal at all, that we were super confidential. It's really funny. I know that we have some problem hospitals or challenged hospitals. I know their code numbers, but I don't know who they are. And even my wife said, that's kind of odd, why don't you know who these hospitals? I said, because that's not how I'm dealing. It's confidential data. I know the codes. I speak to the outreach workers. The outreach workers know who these hospitals are. They outreach. They report back what's going on. But that's the way the system works, and So we've tried to, we've tried to be very careful about that. We have a high-risk infant follow-up database that we're following kids out to 3 years. That's important because it lets the NICUs know what's going on. And we provide opportunity to meet the board's recertification requirement. And neonatology has a requirement to demonstrate activity and quality improvement for recertification. Up to this point, we've recertified over 350 California neonatologists who've actively participated in quality improvement projects. So there's a lot of stuff we're trying to do, and if we can think of other ways to bring value, we introduce them. Building participant value, toolkits and collaborative building is a professionally rewarding activity. And this is a really important thing that a lot of, at least in California, a lot of neonatologists, they're fellows, they're reading the literature like crazy, they do their research, they discuss things with people, and then all of a sudden they go out into practice. And they still read the literature, they still think about things, but when do they get a chance to really discuss? Well, when one of their patients goes bad, they discuss. At an M&M conference, they discuss. Sometimes there'll be a Let's Feed Our Baby Better conference, and they'll discuss. But in general, you have a bunch of professionals, and the same with nurses, who are following the literature, who are thinking about fundamental ways in which to deliver care, that really don't have an outlet for discussing with their peers these ideas, their thoughts, their readings, their stuff. So toolkit and collaborative building becomes a really rewarding activity in that you can come in, you can start to think about, you can be on the feeding committee, and meet with the other people that have been thinking about this. And really, in terms of professional development and satisfaction, I think that being part of these collaboratives are really professionally rewarding. Also, being part of a collaborative facilitates QI execution, as we heard. You can go and use the toolkit, but it's much better to use the toolkit and have people that are supportive and collaborative. And I think it maximizes rewards, and I can't remember what I meant by that when I put down, but it'll probably come to me in a couple days. But anyway, it maximizes rewards. Here's how we're set up. CPQCC is, there's kind of a leadership group. And then we have three big sections. One is the data section. We have a number of databases. We have a database that's kind of an expanded Vaughan database that's about 18,000 a year. We have an acute neonatal transport database that is about 7,000 acute neonatal transports a year. And then we have a database that's a high-risk infant follow-up database to age 3 around California, which is about, at this point, about 6,000 registrations a year in that. And all of these are kind of linked together. So that's the data. We're trying to do research. We haven't had a lot of time to do research in the past because we've been building for 10 years, and now we're starting to do research and look at some of the issues, and Henry Lee is doing that. But the real guts of the program is the Quality Improvement Panel, which was reorganized several years ago by Paul Sherrick. And here's the panel, and it's really important. You'll notice that there are a lot of, there's an analysis panel. They actually look at our data formally every year. They're also following what's going on with JACO and what people are saying and what Vaughan's achieving. So they look at the data. Then once they look at the data, they may say, well, gee, you need a toolkit. So then we have an education committee who create the toolkits and do the toolkit updates, and then organize our yearly quality initiative meetings that are joined with our state meeting. Then we have an infrastructure committee, and they're primarily looking at better ways to do quality improvement, and they're the ones that are looking at the results of individual versus group quality improvement and trying to do that. And then we have a research committee that's, again, trying to do research off of the actual quality improvement. So we're trying to develop quality improvement science. So there's these 4 committees, but the amazing thing is how much work is done by these committees in a month. So every month we've got 10, 20, 30, 40 hours conservatively are volunteered by the chairs of those committees. And then you could see, it's hard to read, but these are really, like this has 6 MDs and 1 fellow and 1 data management and a data analyst, and it's 4 hours, 4 hours, 4 hours. I mean, there's a load of hours here. I mean, an enormous amount of volunteer work. So you have to ask yourself, why are these people spending so much time? I mean, why are they doing this? And they're doing this because it is something that is professionally rewarding. And a lot of us are used to being in committees that are kind of a drag. You know, you're assigned to this committee, and you know, it's a hospital committee and it never goes anywhere, and you sit there and you make recommendations and nothing happens, and it's, oh geez, you want to go back to the ward or go home or, you know, play with your kids or something. So our committee experience in general, is pretty dismal. You know, like most of the committees are, you know, you could do without. These committees are really different. Like sometimes I sit in on these committees and I'm just like I feel like a proud parent, you know, like everybody is just really into it and they're discussing these things. What's the best way to present? What's the best way to do this? And they start quoting the literature and they start talking about their clinical expertise and experience. And it's just, I mean, it just gives you goosebumps to sit in on one of these things and to see what's going on. So the moral of the story is that when you build a collaborative, this is part of what makes it work. You know, this is the kind of building the value piece and figuring out how to do things in a way that makes sense. And sometimes when these committees, we're meeting a lot because of expenses. We meet a lot by the internet now, and it's really important that the chair has a sense that of the timing. You don't want to wear people out. You want to have, you know, you want to really think about how is this going to be a terrific experience and achieve something at the same time. And I know that these are things that we never learned in nursing school or medical school, how to really do a committee, how to really build value, how to make something a worthwhile experience. You know, that, yeah, you got to figure out how to get something done because the administration says that we have to do that, rather than figuring out, wow, you know, as professionals, this is a real need. How do we do this, and how do we do this really well? And as people start to do things better and better, they get even more involved in doing them better and better, because that's part of the quality improvement thing is, you know, every day you go to work, you have 2 jobs: to do your job and then to make it better. That's the thing. So it's like, toolkit in collaborative building is a professionally rewarding activity. I think I talked about that. Facilitating quality improvement execution and maximizing rewards. I wish I knew what this maximizing rewards was. I think I'm going I keep going backwards, you know. So in terms of building a stakeholder, now I'm going forwards. I thought that there are 2 jobs I would really be good at. One is neonatology and that kind of stuff because I like it, and the other is testing forms. Give me a form, and if there's a way to do it poorly, I mean, I could probably make a lot of disclosure money, you know, by being a professional form taker. Also being a professional talker, you know, I got to get these things. So the goal is to build. So one of the things that we talk about in value is to really look at value. And I think that I was so crushed by this statement that, you know, so you did that, you did that amount of improvement. That I was really delighted when I joined with Vaughn on one of their last initiative, and they were really into value. And one of the things they wanted to do they wanted to do two things. They wanted to try to assess the total system impact of an improvement. And they also wanted to look for ways in which to find a way to build value into the quality improvement. So this was pretty new to me, this idea of, well, if you improve a nosocomial infection, what's the total impact on the system? What's the impact on parents, on lab tests, on radiology, on blood bank, on supplies, on pharmacy, on staffing, on length of stay? If you just spread the whole thing out, what was the total value that we're looking at? And here's kind of a grid that just, this is just a grid, and it's looking at personnel, equipment, plant, laboratory imaging, blood products, pharmacy, nutritionals, and family, and really trying to see what the value is. And in a lot of the teams, what they did is that they really sat down and tried to do two things. They first try to fill out this kind of a chart to try to see what are the potential total impacts, and that's good. But what's even better is then you have to really figure out, well, this pharmacy thing, how are we really going to know what happened in terms of the decrease in antibiotics and TPN days? So this meant that they really had to meet with the pharmacy folks and say, gee, we're trying to improve our TPN days and antibiotics. And what they get is, you know, your ordering system really puts us at a lot of stress now that we're talking together about this. Maybe you could think a little bit about how we might improve our ordering system, because, you know, sometimes you do this, sometimes you do that, and there's all these cancellations and stuff. So all of a sudden, it brings up a dialogue with this very important bunch of folks that you're interacting with. It's the same in laboratory, in personnel, that as you start to say, well, I want to look at this, then you have to speak to people in that particular box, and all of a sudden you start to build relationships within the hospital, which in itself is going to improve the quality. In other words, if you have a better relationship with pharmacy, with materials, you know, with the power plant, with all of this stuff, you're going to have a system that works better for you and ultimately improves the care. So this total value approach and the interactions that you have to have with other folks to figure out how to do this is really important. So, you know, like it turns out that for this antibiotic and TPN days is nothing. I mean, they have it, oh, you wanted that? We've got it on the computer. All you have to do is press a button. Do you want it weekly? Do you want it monthly? Do you want it broken down by the drugs you get? So that's kind of a really important thing to start looking at this. The other thing that they did, besides looking at this value, is that they looked at waste. And we talked a little bit about that this morning, about trying to put out a whole process. And what happened with CLABSI, or nosocomial infection reduction, is almost everybody discovered that they had terrible protocols for stopping antibiotics on a rule-out sepsis. I wonder if that was what was found here, but in this particular collaborative, almost everybody, after the first couple meetings, they said, oh, we're working on our rule-out sepsis, because it turns out that kids are getting too much antibiotics. And so this kind of thing starts to spread in terms of, well, you're preventing CLABSI, but it turns out that your rule-out sepsis, you know, and that's kind of important for when to pull the line, as well as the 120 ml. So this kind of approach is a really important approach. And then it gives you the kind of material that you need to speak to the person that you're speaking to. So here's the elephant of value, and what are the values of what values have been identified that are major consequences of QI? What exactly does it mean to the infant? What exactly does it mean to the family? What exactly does it mean to the staff, the administration, and the stakeholders? If you start to think this way and do a QI and map it out this way, your sustainability as an organization becomes really enhanced, because you're starting to build a really solid, valid picture. And then people start to say, well, you know, this is threatened and they're kind of important. And here's why they're important, because you've shown them why you're important. And it really depends, you know, like personnel, there may be some places where nursing is in terribly short supply, you know, where they really need more nurses. If you can then decrease your infections and show that your nursing load goes down, it's really important. And then you can actually look, because some people have looked at this, at your turnover. It turns out to hire someone new and train them is very, very expensive, and turnover is a big deal for administrators. If you can show that after you've done a few QIs, that the stability of your staffing is much more stable and your turnover is changing, then all of a sudden you can say, hey, we really need money, we need support, we need to do this, and look what we've done in terms of staff turnover. So kind of important to, again, and why would you pick on, why would you do that? Well, it's knowing the strategic plan and the problems within your institution. If you've got loads of nurses, that's not going to, you know, reducing turnover is not going to be as big a deal as if your pharmacy costs are really skyrocketing, and they've been trying to bring them down and they can't really bring them down, and then you can go in and show that you've done tremendous reduction in pharmacy, both by having fewer infections and by, in the course of doing this stuff, by having a slicker rule out sepsis, so that the kids really only get a very short course of antibiotics. So kind of important to think about that. There are several models of support. There's the corporate Intermountain Health we heard about in pediatrics, and that's great if you have, because then they have the data systems and they put everything together for you. So that's very helpful to have corporate support. Top-down is the one that's very troubling. It's absolutely essential to get started. You can't do this on your own. You really need someone has to put up the money to get things get going. The problem with top-down is risky sustainability, and because even with the best intentions, economy rules. And you know, we have a wonderful relationship with our state children's services, and they support us in many of the things that we do, especially the high-risk infant follow-out up to 3 years. But they're taking a big cut, and so they come to you and they say, we're really sorry, we love you, but we just don't have the money. So top-down, even if you have wonderful relationships with those folks that are giving you the money, is really it's sustainability-wise, it's kind of dangerous. So it seems to me that membership is really the way to go. And membership could be either required, expected, or valued. And in California, in CPQCC, membership is required in that the state requires that we prepare the reports, for the yearly reports for the state. We haven't gotten any kickback on that, mostly because we're providing a lot of value. The downside to that is that when we put on a quality improvement collaborative, because everybody's forced to join in a certain sense, we feel that we have to have a Volkswagen version price-wise. So I think the usual like collaboratives cost in excess of $30,000 to really get in there, and we charge about $5,000 to $7,000 for a very intensive face-to-face collaborative that meets all the IHI criteria, and sometimes we've even gotten little grant support, so we give money back. So required. Expected is kind of interesting in that there was a time when certain payers were cutting contracts in California, and they'd say, well, are you members of CPQCC? That's before the requirement. And so there was encouragement by payers for hospitals to be part of some quality improvement organization, because they know that the better the quality, the less likely, that the lower the complications and the less they're going to have to pay. And then there's valued, is it something that's membership is kind of valued, and it is highly valued. Vaughan has over 700 members. They're all voluntary, and they value membership, and that's how they do it. So again, I think that even in terms of support, if you're going to go to a membership, the way to if you have a maximum product for a minimum effort and cost, that's kind of the way to go. In California, we have our CMQCC, led by Elliott Main. That's the California Maternal. We're trying to address 550,000 births in about 290 sites, mostly stakeholder support at this time, but we are trying to use green data that's targeted to national expectations, and I'll talk about what green data is about in a minute. CPQCC, about 18,000 infants a year and 132 NICUs. Core member support, it's mandated by CCS. And then our high-risk infant follow-up, about 6,000 a year. At this point, state support, and we're in a very sensitive period. So CPQCC we're solid at. High-RIF, we don't know how we're going to get paid for in the future. CMQCC, we're hoping that we're going to be able to switch to stakeholder support. It really depends upon how much value we could build for the stakeholders, whether they're going to be willing to join or not. So let's just talk a little bit about data systems, because everybody talks about data. There's kind of the traditional databases like Vaughan, CPQCC, NICHD. It really asks, who do we care for, how do they do, and it gives you a sense of what QI you might want to do. It gives you a little bit of feedback on whether it's working or not. That's kind of traditional. The next step is an improvement-specific information system, and we did that with California Perinatal Transport. We had focus groups to say, if you had the ideal data set, what 5 things would you improve? We prioritized those, and then we built the data set around these 5 issues. So the data supports improvement in 5 specific areas. It took 35 variables to do that, rather than the 250 that are kind of recommended. Now one of those is a scoring system, so it's maybe more like 50 variables, but it's still a lot less than 250, and it's kind of green data, in that each item is a working item. There's nothing, in other words, if we don't ask for sex because that doesn't drive anything. We get a different way. Every single item drives something. It's either a risk adjuster or a outcome measure. So that's kind of the second stage. But the new thing is the multi-level improvement-specific green data system, and that's our CMQCC. And what we're doing here is we're recycling data in real time. So hospitals have birth certificates and universal patient discharge billing. That's where the ICD-9 codes come from. And so what happens is that traditionally hospitals just throw that stuff away. They send the birth certificates go to vital records, and the universal billing goes out to whoever. And so what we're doing is capturing this data and then recycling it, and we're recycling it so that we can get quality improvement goals that are becoming universal. So we take this data, we recycle it, and we use it to get reports that are being asked by many folks. And then we do a multi-level analysis where you can see a point like percentage of early term deliveries. Then you click on the point, and then you can see all the patients who were in early term delivery. And then you can ask certain questions that might relate to why they're in early term delivery. You know, in other words, because the gestational age was wrong, or et cetera, et cetera. So it gives you a root cause analysis. So it's the first data set that's very, very unique in that it used recycled data. It's asked questions that are the data's collected to ask questions that are very specific to quality improvement, and you're able to go from a dot that summarizes your whole hospital to opening up a table of all the patients that actually were in that dot. And this is a highly secure thing that you need passwords to get into the first level. When you ask for patient data, they call you on the phone, you have to register your phone, they call you on the phone, they give you a password, you put the password in. We can never see the patients, but the hospitals can see the patients. We see, you know, codes and are never allowed that level of access. So here's how it's done. We have the two files, the ICD-9 file and the birth certificate file. We put them together, and then we do reports. Some of the things actually you have to do chart review, but as was explained this morning, rather than reviewing all these charts, we can tell you which charts to review, which really say, here's 25 charts, review these, and so a lot of time saving in here. So we think that this is incredible value that we're trying to build. Here are the quality measures, again, that are being tracked in this data report, and some of them they're all National Quality Forum, some Joint Commission, some LEAK programs, some California medical systems. So again, we're trying to look at important quality outcomes using recycled data. The hospital really doesn't have to do anything. Their lawyers do a lot because there's a lot of legal stuff that has to go on as we demonstrate how confidential these systems are. And the major expense for a system like this are all the firewalls and the security things that you have to build into them. And here's just one of these reports. The reports are very interesting because you have the possibility. You could look at this weekly, monthly, yearly. So it's not only a report, but it can be used as a control chart as you're doing your quality improvement. So here's a point here, and then if you want to, so we've got the state average, the region average, and then we've got you know, the hospitals, the actual hospitals average. And the interesting thing is that at this time, we've got about 20 hospitals that are reporting. We've got about 60 hospitals in the pipeline. Our goal is 290 hospitals, but from last year's data, we can get all 290 hospitals. So historically, every hospital in California that delivers can get their last year's stuff. The hospitals that are active can get real-time. This is all a real-time system. So you wonder what's in that. Point there. And now here it opens up for the hospital. There's a lot of facility, like you know, who knows these ICD-9 codes? You hover and it tells you what it is. And for driving quality improvement, it also, for all of these cases, there's a window that tells what each practitioner rate was and their contribution to the overall rate. So you may find that there are 3 obstetricians that are generating all of these early term deliveries, and then you can kind of point this out to them and make sure that they're enrolled in the next QI cycle. One of the things that we do when we put on a QI, we send everybody a letter with a confidential letter with their confidential standing, because they may not have looked at their report recently. And those that are particularly challenged, we might send a special letter to and say, you know, this is confidential, we don't share it with anyone, but it looks as though you're particularly challenged. You may want to enroll in this in our upcoming. And it turns out it's very successful because in general, folks that join our quality collaborative, because they're very intensive, it's only like 30, the people that sign up first are folks that really are challenged. And during the course of the QI, they usually catch up or sometimes exceed the pack. So CPQCC goals, which I think is really is to maximize value by having assessments based on national standards as well as local need. They minimize extra work to obtain these assessments. Again, this kind of screen data idea. They facilitate quality improvement activities and build towards core membership support. And whether we're successful or not will depend upon, I think, whether we get everybody signing up as members to support this. So that was that was you know, kind of a project. That was collaborative sustainability, and as I say, it's very simple. Look for ways to generate value, and I hope I've given you some suggestions on how you might do that. And now we'll talk a little bit about project sustainability. I think that holding the gains really begins with a solid foundation. You have to have motivation to change the standard forever ways. And you know, like, people are doing these things, they're doing these things, and the big question whenever we bring something up is, why should I change? You know, like, we're doing this forever. Why should I change? So you really have to motivate, and a lot of the motivation is to show them that other people are doing really much better than you know, that they're not that they're lagging behind, and that's very, very effective. You know, that a lot of places, you know, as soon as you know that you're not doing as well as other folks, it really gives you an impetus to, you know, why should we be second rate? And we hear that. That's a term, you know, like I've heard people say, why should we be second rate? You know, and especially, they don't know who it is that's better, but they know, and they can look in their region. Not only, you know, in California, you can even look in your region. So not only across the state, but then all of a sudden in your region, you know, there's 30 hospitals or 20 hospitals in your region, and wow, there are some guys doing really better than you are, or gals doing really better. So this motivation is really important, as well as showing that you know, it's up to engaging hospital and NICU leadership is really important. And I think we've done a really poor job of engaging hospital leadership, but we're trying to do that. Vaughn's trying to do that also. NICU leadership is also important. There's some papers now that show that in those NICUs where the head of the NICU goes on rounds, actually goes on rounds with the folks to inspect the site, the PICC line sites, etc., that they do really, really better. That leadership rounds is really, really important. Adapting efficient solutions is really important. Standardizing the works with protocols, checklists, and audits. And it's really important that when you start, it's just like everything. You know, when you start learning the piano, you got to do a lot of drills every day, a lot of drills. As you get better, if you did all those drills every day, it's kind of stupid. But you do have to do some drills. And I think the same thing is with audit. That it's clear in California with oclapsy that those places that held the gains did audit after audit after audit during the initial period. And these audits assured that what was going on became their culture, their way of life. But after they stopped, after that first year, you don't have to do intensive audits every single day. So one of the things to think about is how to audit and how long to audit. Now, I think you have to audit forever, but you don't have to do it every day. So there are some ways to do it. There's the deck of cards. Everybody know the deck of cards? So you have a deck of cards and it says check PICC lines, check are the kids, have they made other kids on PICC lines who have 120, check hand washing, check this, check that. So you have a deck of cards that for all of your QI projects give some of the key things, and then you pull it out on rounds, and then as you go on rounds, you do that check. In every day, there's kind of like a different check. So you can do it that way, and I think that that's a pretty interesting way to do it. You can also have secret shoppers. Secret shoppers are really important. You know that you get a girlfriend or a boyfriend to come into the NICU, you know, once a month and look around. Are people washing their hands? Are they doing that? Or you get a adult ICN nurse to come down and take a look at some more sophisticated things. And this doesn't have to be every day, but it has to be, you know, you have to sit down with your team and say, how are we going to do this? So we'll audit X amount of time, but if we fall below this, then we've got to have a reinstitution and then re-auditing, and then, so kind of like a sliding scale, you know, like the better you are, the better you're doing, the less you audit. The worse you're doing, the more you audit. And people don't talk about these things, but these are the kinds of things that make sustainability, because you're only going to be sustained if you have an efficient solution. If you're trying to do hand washing and your soap dispenser is still over there, you can be sure that as soon as the project's over, your hand washing is going to go down, because no one is going to walk over all the way over there to get that soap. It's just not going to happen. It's an old kind of old-fashioned example. So standardizing work, protocols, checklists, audits are really important. Minimizing the extra work of data collection is really important. So the more you can get recycled data, the more you can pull out of. So that kind of makes this kind of very adaptive and exciting. And then participating in a community of learning is really important, and a source for innovative solutions and its support during a difficult set of tasks. So again, I think this is important, and you don't need a huge formal community of learning. We heard here, you know, if there are a few hospitals that you know that are doing it, and you chat about what's going on, and you say, okay, the three of us were in this collaborative, now we're having trouble keeping folks to do that. Then you call the other people and let's have coffee. You know, are you having the same trouble? What are you doing? Oh yeah, we had it, but we did this and it really worked. So these are kind of suggestions for holding the gains. The battle plan to defeat your standard way forever way is a clear picture of what's needed to succeed, identifying the forces that will promote and impede, and then continuing reassessing. I think a driver diagram is really important. So I like to start with the fishbone because it helps you do the driver. The drivers are kind of the key things in the fishbone. So then once you have the drivers figured out, then you can figure out the change strategies. So this is really important. And the reason this is so important is you want to make this as simple as possible. In other words, you want to find solutions that are simple and not convoluted and difficult. And although I have to say, some of these things are hard to do. I talk about flossing, you know, like flossing is really easy. Everybody, you know how important it is. And most people do it starting about a week before their dental visit. And you know, and you have to ask yourself, well, why is that? You know, why is that? I think, so how do we promote, so when we talk, you know, when we talk about this stuff, that even in our everyday lives, there are things that we should be doing that are hard to do, that we know are good, that aren't too difficult to do, but we kind of don't do it routinely. So I like the driver diagram. It kind of tells you what to do, but then what do you do when you're not making progress? And I really love this. The force field diagram is I think is a really important issue. So what you do with the force field is you take your aim, that you're trying your strategic aim, and you try to look at the forces that restrain a limit change in the forces that drive change. And these are, you know, everybody knows this in their gut. You know, everybody knows it's those neurosurgeons that never really wash their hands. You know, I mean, everybody knows that. So that's a force that it's impeding. But when you start to do this, when you start to actually use these tools, it comes together, you know, and all of a sudden it's not, oh, we'll never be able to change those neurosurgeons. Now it's, okay, there they are. You know, like how are we going to do it? What are we going to do? How can we be creative? Like what are the ways in which we can really do it? Should we use the parents? Should we use the hospital administrators? Should we use education? You know, how are we going to do it? So these force field diagrams, I think, very formally using fishbone, using the last slide, in using force field, give you kind of tools to really solidify what you're doing so that it's not just a one-off. These are tools that help you look right into the fabric of your day-to-day, because it's the fabric of the day-to-day, the culture, that's how you do things around here that really is going to make a difference for sustainability. Hardwire the new approach. You know, you have a new approach. Is it really working? So PDSA you heard about. Generate a blame-free failure frenzy. I love that. That wasn't mine, that was someone else's. Generate a blame-free failure frenzy. You know, one of the things that happens at a really effective program is that when they have a failure, they really go to town and try to use that as a root cause. What happened? Did we break things? Did we not think of something? And the important thing is it blame-free. Once it becomes blame-free, it becomes fun and it becomes really intense. As long as there's blame there, everybody's going to keep their mouth shut, because God forbid, if they're not blaming themselves, they're going to blame someone that's a friend or someone they have to work with. So this building the blame-free is a really important. Leadership rounds to say, you know, we really value what you're doing as leaders. We really value this. Broaden the players, looking at all the impact partners, really important. If you're talking about respiratory therapists, and you don't have respiratory therapists, and you don't have all the people, even the maintenance guys for the respirators involved in that, you're probably not going to change the culture in the way you would if you just had the docs who are writing the respiratory orders or you know, the head nurse. So, and finally, audits. I've just been so impressed with those who audit and audit and audit, seem to hold their gains. And finally, in terms of the project, one of the questions I'm trying to ask for CPQCC is, what's our commitment? You know, they used to start with 1 year because that was IHI. And I really had a fight for 18 months. I said, you know, we want to go out to 18 months. We want an 18-month get-together. It doesn't have to be all of the data, but we want to keep at least look at the key data elements, and it doesn't have to be face-to-face. It can be on a web. But let's get that 18 months out there so we see what's going on. And we were really excited because what happened is that the things were actually improving rather than decreasing. We were getting gains that were going on. But I think that I like to see CPQCC have a 5-year commitment. So if you're part of one of our quality collaboratives, that we really support you for 5 years. Now, how we support, I'm not sure. What kind of data we're going to, I don't know. But I think that there should be a commitment that you put on a quality. It's not a 1-year IHI thing. It's yeah, we're going to help you get started in a big way in the first year, but then we're going to run out to 5 years to make sure that you hold the gains. And then the question is, how do we monitor our gains? You heard how awful it is to have to keep filling out these forms that are really big forms. Well, the big forms are needed initially. Maybe they're not needed for follow-up. And maybe there's a green solution. Maybe there's a green solution off your medical record, your electronic medical record. Maybe there's a green solution off your Vaughan report that will do this for you, because the less you have to do, the more you can devote to actually doing the process rather than recording the process. So in exactly what will we do, and that's focusing on efficiency. So I know that the hour is getting late. I just wanted to show you that as you know, you can really do something. So here's a hospital, Santa Clara Valley Medical Center. They started off with hypothermic kids. 45% of their preemies were hypothermic, way above the pack. I mean, this is really outrageous. compared to what everybody else was doing. And they instituted their very own QI and were able to drop it down. And then they got, it's kind of interesting, they got kind of, they forgot about things and then it popped up. But fortunately we were monitoring and said, oh, that's too bad because you've popped up. And then they really went to business again and they popped down. This gray zone is because we're in real time. The real-time values are not fully closed, so we do it in gray. So that was a pretty good experience, we thought. And then here's one from Anchorage, and I love this. They went, they're probably longer now, but this was done a while ago. In their last intersepsis interval was 425 days. And the reason I show this picture, this is a really active NICU. I mean, it's, you know, there's alarms going off, there's all kinds of stuff. So it's not that, you know, you can achieve this if you don't have, and they go over census as well. So this is a really big, you know, it's a pretty active NICU that's, and yet they've gone 425 days. But I can tell you that they're really, really into doing this. You know, they have leadership rounds, they have all kinds of stuff going on. They have a sign, some of the places that when they go over a year, they buy these electric signs, you know, that say, you know, 370 days without an infection, and it's right over the sink and it rotates. Actually in Texas they do, there are many places that are doing that. I always thought it would be terrific to have a video loop, so you wash your hands, right? And it gets looped up on this screen that just plays for a while until the next person washes your hands, and there's a clock on it. So you look up there, and, oh my God, I did a 5-second wash, you know, and everybody's seeing this over and over again. No one's ever tried that. Maybe that's too much like lame. I've gone over a little bit, but I'm sorry for that, but what can you do? Oh, here's the slide that we were looking for. I guess it's just as good here as it was in the first talk.
One or two quick questions.